All right. Good afternoon, everyone. My name is Matthew Terry, and I'm an advancement manager here at CSG. Today, it is my pleasure to welcome you as we continue to celebrate Innovation Month at the Council of State Governments. We hope you enjoy and learn a bit from today's program and continue to make plans to join us next Monday as we complete the series that has discussed a broad range of topics from healthcare to finance. Today's Innovation Classroom, Innovations in Diabetes Treatment and Prevention, is brought to you by the Diabetes Leadership Council. And now a few reminders before we begin. This presentation is being recorded. At the conclusion, it will be available, but sometime this week, it will be available on the CSG website. And as you will note, only speakers are able to turn on their cameras and speak today. We encourage audience members to type any questions that arise at any point during the presentation into the chat. Please direct them to me. Again, my name is Matthew Terry, or to everyone in the chat, and we will address them following the presentation. Quickly, as we begin, I would invite everyone to put your state you're visiting from into the chat so we know where everyone is joining us from. And as we begin, I will kick it over, and I'm pleased to introduce today's speakers, George Huntley, who is the CEO at the Diabetes Leadership Council, and Erica Emerson, the Chief Policy Officer at the Diabetes Leadership Council. And so thank everyone for participating and joining us today. And George, I'll turn the program over to you.
Thank you, Matthew, and good afternoon, everyone. Thank you for joining us today for a conversation on diabetes management and innovations. Very pleased to be with you. My name is George Huntley, and I am the CEO of the Diabetes Leadership Council. I'm also a patient living with type 1 diabetes for 39 years. I'm a past national chair of the board of the American Diabetes Association. Been an advocate for 30 years, and we'll get into that in a second. And I guess in the only other comment that I'll make in my other day job, I am the chief financial officer of a professional services firm based in Indianapolis, but in states across the country. And in that role, I've been the plan administrator of a self-insured employer-based plan for over 25 years. And I'm pleased to be joined today by my esteemed colleague, Erica Emerson. Erica, why don't you say good afternoon and tell us a little bit about yourself.
Of course. Thank you, George. And thank you, everyone, for joining us today. I'm Erica Emerson, Chief Policy Officer for the Diabetes Leadership Council. My background is in health policy, and specifically health policy related to care and coverage of chronic diseases. Been working in this space for many, many years, but have a real passion for improving the way our country takes care of people with diabetes, makes it easier for them to manage the disease, and in turn helps lower or bend the cost curve for the nation's cost to manage diabetes. So with that, we can move on to the next slide, George.
Talk a little bit about the Diabetes Leadership Council. And one thing I would also like to just reiterate is, as you have questions throughout this presentation, please enter them into the Q&A here, and we are delighted to go through those. So the Diabetes Leadership Council is a small but mighty group of past leaders of national diabetes organizations that have advocacy expertise. We provide policy expertise for lawmakers. Everybody on our board is a past leader from a national diabetes organization, many from the American Diabetes Association, but also from others. We've got scientific sessions, scientific advisors, as well as staff, and we are located really spread nicely throughout the country with board members from Alaska to California to Florida to Arizona. So we can get involved at state level issues and provide expertise for those that desire. I'll let you advance that, Erica, if you're...
I'm trying, yeah, it's not wanting to go forward.
Try raising your left foot slightly. There we go, almost.
We'll have to do it a different way, yep. All right. We will jump in with a sort of a quick grounding for all of us on diabetes. As many of you maybe are aware, there are different types of diabetes, but there are three sort of universals we want to make sure that everybody kind of keeps track of today as we're talking about diabetes. First is the disease itself, or the collection of diseases, affects how the body converts food into energy. We'll get into some of those specifics, but I would consider this a policymaker's view, not a scientist's view of diabetes. So we won't get too deep into the weeds on the biology of it, just to make sure that you have a policymaker's understanding of diabetes and the people that it impacts. Diabetes is a recognized disability under the Americans with Disabilities Act and the IDEA acts related to education. This is important to keep in mind as we go through. For me, again, the layperson's view, think of diabetes as basically people having a pancreas that can't do the job that nature intended. This is through no fault of their own. So when we're looking at diabetes policies, we want to make sure that we're looking at it through a disability lens to make sure that people's civil rights are protected. And finally, as exciting as it is, we're going to cover some really fascinating innovations in the diabetes landscape. It has completely transformed over the past few years, and looking ahead, some very, very exciting innovations on the horizon. But right now, there still is no cure for diabetes. And some of the innovations we're going to be talking to you about today, we are finding more often than not, there is not equitable coverage and equitable access to those innovations for all people with diabetes, particularly in communities of color and other underserved communities. This is not wanting to move forward. All right. So as many of you know, insulin is probably the top thing you will hear about when it comes to diabetes policy. And that is because insulin is the key. It is basically a hormone that helps the body take sugar from the food that you have consumed and convert that into energy that your body needs. So people who have type 1 diabetes, they can't produce insulin at all. People with type 2 diabetes, that is considered a metabolic disease, and they are either insulin deficient or insulin resistant, meaning their bodies can't produce enough insulin for them to manage their blood sugar. So insulin is a necessary, it is an essential medicine for people with type 1 diabetes, and increasingly for people with type 2. As we've understood more about the disease and how it progresses, more and more people with type 2 diabetes are going on insulin and going on insulin sooner than they have in the past. So right now we have about 1 in 3 people, or 1 in 3 adults with diabetes require insulin daily to help them manage their blood sugar. George?
Thank you. And managing it is so critical because the management of diabetes and management of the blood sugar helps prevent or delay the complications. And the complications of diabetes is where the cost and the devastation comes from. So the ramification of high blood sugar, regardless of how you got to high blood sugar, the ramifications of high blood sugar are one of the leading causes of blindness, diabetic retinopathy. 1 in 3 aged 40 years or older have some form of diabetic retinopathy. Heart disease, you're 2 to 4 times more likely to die of heart disease or stroke. 44% of new end-stage renal failure, so kidney failure. It is a devastating area, and these things are very expensive. Lower limb amputations, 60% of non-traumatic amputations. It's the largest cause of amputations other than injury. So these are the reasons why it's important to manage these blood sugars, because the cost of these complications on the right-hand side are far less expensive than the cost of the management tools, the medications, the devices that a patient needs to succeed. So, there are 1 in 8 adults in this country have diabetes today. That's 37 million Americans. And the number with pre-diabetes is over 95 million Americans. It's 1 in 4 healthcare dollars. And I'm going to skip over here on the right-hand side, 60% of our spend is on the complications versus the management of the disease. So we're not spending our money wisely. We're spending our money on all of the bad things that if we had designed it appropriately, could save both the government and honestly the patient a lot of pain, a lot of cost, both obviously financial as well as emotional and health.
I think one more point to make on that. Right now, with Medicare and Medicaid in particular being the largest public payers of diabetes, part of the impetus as policymakers is to make sure that we're focusing on access to standards of care earlier in people's lives, particularly during their working years, because what we don't want is to perpetuate what's going on now, which is this massive cost shift. Instead of making sure people have access to what they need in their younger working years, we're really paying for that down the road when they're older. They're reaching Medicare age and poor health, and frankly, reaching the state of dual eligibility much, much sooner than they otherwise would have.
And here we'll talk about the disparities and inequities that happen specifically in diabetes. This is a genetic disease. This is a condition that is, it's not the patient's fault. This is the genes that they were dealt, but there are racial and ethnic disparities in here. The 7.5%, and we're missing the little marker on it, but those are the non-Hispanic white community is at 7.5%. And the Native American, Alaskan Natives are nearly double the rates of diabetes. You go to some of the Native American reservation areas and over half the population will have it. It is devastating in some of those areas. So it is not an equal opportunity disease. And this is not something that the patient can do much about from the standpoint of it's in their genes or it's not in their genes. The other piece is that people of color and not versus non-Hispanic whites, their rates of diagnosis, but their rates of death, hospitalization for lower limb amputations, end-stage renal disease, all of these things are proportionately worse for these communities, not just because they have a higher incidence rates of diabetes, but because their access to the current standards of care are lower than the non-Hispanic white communities. So depending upon the breakouts of your state, these numbers could be better or worse. But overall, it is a stark inequity amongst patients living with diabetes.
All right, now with that grounding, we are going to pivot to talking about innovations, the theme of this month's celebrations at CSG, and look at some of the technologies in terms of medication and devices that are changing the diabetes treatment and management landscape, the prevention landscape for diabetes, and what you as policymakers need to know to make sure that your state is diabetes friendly. Right now, what we see here is a lot of room for improvement. Diabetes is a really complicated condition to manage, as George mentioned. So we see right now, again, that we are spending a lot of money on complications and less on prevention. We have really too many ER visits per year, too many inpatient stays per year. These are all indications of crises. Diabetes that has eluded control or management for the individual, suggesting they don't have tools that they need to manage their disease and keep them healthy. Part of the reason for that is the way diabetes is managed is really different from a lot of other chronic conditions in that it is self-managed. So out of, we always talk about this in rent, 525,600 minutes in a year. Out of all of those minutes, a person with diabetes spends less than 120 minutes with their healthcare provider. The rest of the time, morning, noon, and night, they are making those decisions on their own, what to eat, activity level, how much insulin to dose, what type of insulin to dose. All in all, kind of culminating in about 180 additional decisions per day on top of all of the decisions they have to make for their jobs, for their families, for all the other roles or hats that people wear. Diabetes is another series of decisions that kind of get layered on top of that. And what we hope you'll come through or pull through in a lot of our innovation discussions is much of the impetus is making sure that people have access to the information that they need to make good choices for their health. George?
So thank you, Erica. And I will not go through everything on here, but the point here is it's not one size fits all. And every day is different. In fact, every hour is different. I've been living with this disease for 39 years, and I still have to struggle because there are so many variables involved. So number one is food, all right? The carbohydrates that I eat are certainly going to cause my blood sugars to rise. But is it simple or fast carbohydrate, or is it a more complex carbohydrate that slows down when it happens? If I'm eating pizza, the fat in the pizza will slow down the absorption of the carbohydrates, and therefore my insulin needs to be slower in the body than if I'm just eating a piece of plain bread, if you will. Caffeine, alcohol, all of these things impact it. Obviously, medication is going to impact your blood sugars, but then exercise. Light exercise will lower my blood sugar. High intensity exercise can actually raise it. Or more particularly, a short jog will lower it, but weightlifting will raise it very commonly. So these are all kinds of things that impact what's going on with that patient, back to the 180 different decisions that get made each day. Am I stressed? The fight or flight, as you go back to caveman days and we were running away from the lion. Well, our body gives us a shot of glucose so that we can outrun that lion. But the same stress is there if we have a deadline to meet or we have a presentation to make, like today. If there's a stress there, it's going to raise your blood sugar. Did you get enough sleep last night? All of those things. There are so many different variables that it requires a lot of decision-making and juggling to get it right. And hopefully the takeaway of this is you can't rely on the patient needs all the help they can get.
And they need continuity. So when people find a treatment regimen that works for them, be it a device or technology, a medication, once they find something that works, it makes sense for everybody to keep them there and not switch for non-medical reasons, which again, we'll get into later. But continuity of care is critically important.
Yeah, that's a very, very good point. So innovation is reshaping the landscape, and there has been quite a bit of it over the past decade, and really even shorter in the last 5 years, the things that are coming out. So you may not have been used to seeing the charts at the bottom of this graph. So one of the things out there today is a continuous glucose monitor, and a continuous glucose monitor is a small sensor. I have one on my arm that will provide a blood sugar reading effectively every 5 minutes. And when I get that blood sugar reading, I can tell whether I'm going high or whether I'm going low or whether I'm stable. So it not only tells me that point in time, but it tells me the direction I'm heading, which is very, very important. So prior to CGMs, continuous glucose monitors, all you had were finger pricks. And finger pricks are one point in time, and you might test yourself 5, 6, 7 times a day. And you had 5 or 6, 7 times, but now you're getting one every 5 minutes. What you really want is to keep time in range. So the graph that you're seeing here between those green bars on the left-hand side, that left-hand chart, you really want to stay between that 70 to 180 range because that is where the best control and your best chance of avoiding the complications and delaying those complications. With the tools of the continuous glucose monitor, I now can see the impact of what I've just eaten, how my activity has impacted me. And now, in addition to this, there are insulin pumps that now talk to the continuous glucose monitors. So the insulin pumps will give me a background dose of insulin, but they now talking to the CGMs, really effectively in the last 3 or 4 years are very effective at stopping the delivery of insulin if the patient is dropping, and actually giving a little bit more insulin when the patient is going high. It's not quite an artificial pancreas. We are not there yet. You still have to take a dose. If I'm having a meal, I have to tell it I'm having a meal. But we are coming into the future. There will be a closed loop system where the insulin pump will be able to provide that almost automatic control. It's never going to be perfect, but it's a lot better than where we were 5 years, 10 years, 20 years ago. I've been on a pump since 1994. I assure you they've come a long, long, long way. And the more we can get that patient to be in range, the better it is, obviously, for the patient's health, but also for avoiding all of those just devastating complications.
And for those of us without diabetes who maybe don't understand what these different technologies do, I liken it to the dashboard of your car. When you're operating, a complex machine like your car, your speedometer, your odometer, all of these controls stay on the entire time you're driving. So you can take in information and decide what you need to do with that constant input of information about your car and your surroundings. It works in the same way. If someone doesn't have access to these technologies, it would be like your dashboard coming on when you turn on your car and then shutting off. And the rest of the time you're driving, you're flying a bit blind. So again, more information to help people make decisions to manage their health. So one of the newest categories of innovation we're going to talk about is a medication called GLUCAGON. GLUCAGON is a medication that helps people with diabetes treat very low blood sugar levels called severe hypoglycemia. Or actually more accurately, typically it's a caregiver, a teacher, a school nurse, a parent. Someone needs to intervene when the person with diabetes, their blood sugar has gotten so low that they're not able to kind of self-treat to help bring that blood sugar back up to a safe level. So the new glucagon products that have come out in the last couple of years are much more user-friendly. We'll show you some product pictures in just a second here. And that really has made it a lot easier to have glucagon available at school, at work, and at home. A lot easier for school nurses to be trained. And critically, more likely to be used effectively in an emergency. The older glucagon kits that were available look almost like a little chemistry set. There were a lot of steps involved, which served one as a deterrent for people to actually intervene in an emergency, or when they didn't always administer enough medication or administer medication in the right way. So these newer glucagon products really are an important advancement in safety and preparedness. So some of the policies you will be seeing as policymakers, again, deal with emergency preparedness or disaster preparedness, depending on where your state is and what your weather is like. Diabetes care in school, pharmacy practice laws, scopes of practice, and obviously disability rights, as we had mentioned earlier. And one little kind of technical issue that you might see, at least we've seen in the last couple of years, is making sure that your legislation is product agnostic. Because the landscape has changed so much, it used to be that these products could only be injected. Right now, we see there are pre-filled pens and syringes. There's a product here called Baqsimi that just gets administered up the nose. Those aren't injectables necessarily. So when you're writing legislation or looking at policies that impact access to glucagon and other medications, is just to make sure that it uses a term like administer. So it isn't, I guess, baking in any preference for a particular product, because ultimately we want the choice of what glucagon is prescribed, particularly to a child in the school setting. That should be up to the family and the healthcare provider with some input from the school nurse. We don't want it baked into the law that kind of prefers one type of product over the other.
So we've talked about managing the lows. Now let's go to managing the highs. And biosimilar insulin. You've all heard a lot of the issues about the cost of insulin and how it has been skyrocketing. And you're hearing from your constituents and the patients about the unaffordability of insulin. And we have many options for you if you go to our website to help a patient get access to insulin. But biosimilar insulin is one of the keys for the future of this. So what it is an FDA approved medicine that's similar to another biologics. That biosimilar, it's similar to a biologic. Insulin is a biologic because it's injected. It comes in a vial and has to be injected. It's made by using living cells or living tissue. And the biosimilar, as one might hope, is typically less from a cost perspective than the reference or original biologic, usually in the neighborhood of 30% or more or less. So the good news is there's more products available today with even more on the way. And the competition is driving down insulin net costs. And the key word there is net costs, because the list price of insulin is it's actually leveled off in the past couple of years, but it's still very, very high. And the biosimilar insulins have not impacted the list price of insulin, but they have in fact helped drive the net price. Now, the net price is what an insurance plan actually pays. The list price is what your constituent is going to pay at the pharmacy counter, a fully insured person at the pharmacy counter, which we'll touch on in just a moment. But the considerations of this whole insulin and the is pharmacy practice, and there's an interchangeable biosimilar. Can the pharmacist actually interchange that and substitute that? Insulin copay caps to make insulin affordable for those under state level plans. State level can't impact Medicare, and it can't impact an employer ERISA plan from a cost perspective, but there are still many plans that can be impacted, if you're looking at that. Health plan and PBM, pharmacy benefit manager regulation. The pharmacy benefit manager is the player in the supply chain that is deciding and driving the formulary of a plan. So their job is to establish the drugs that are going to be covered by a health plan. They then negotiate with the manufacturers to establish, again, that net cost for the plan. The way they get to that net cost is by a prescription drug rebate. They get the manufacturer to pay them a rebate, and it goes through to the PBM. The PBM keeps a piece of it and then sends it up to the health plan or the government or an employer in a ERISA plan. But the pharmacy benefit manager, because they have a piece of it, has a incentive to keep the higher priced drug on the plan. And so one of the issues are biosimilars, which are going to cost the state less, are they covered under your plan? And that's an area where you can look at and decide in the state exchanges and the state employee health plans. Now here's a listing of this. And so the list price of Humalog, Novolog, both of those are short-acting insulins. Lantus on the left-hand side is a long-acting insulin. You're looking in the upper 200s. In fact, there's some retails that are going to be over 300, but upper 200s for a vial of insulin. Now you go over to the right-hand side, and these are the biosimilars. Well, you can see that the list price on Humalog drops to $233 for Admelog, certainly better than $275, but still pretty expensive. And then you see insulin Lispro at $82. Well, interestingly enough, insulin Lispro is made by Eli Lilly. Humalog is made by Eli Lilly. It's the same drug coming through the same manufacturing facility, going into the same vial, but getting a different label slapped on the front. That different label allows Lilly to sell it at a lower price without being in breach of contract with their pharmacy benefit manager agreements. And so that's $82, which is far closer to the net price of what they were making on the drug anyway. Novolog in the Novo Nordisk product, insulin aspart and Relion are both, all three of those drugs on that line are the same drug from Novo Nordisk, same plant, same vial, different label on it, packaged for different reasons to sell through pharmacy benefit managers. Lantus, which is the long-acting drug, Basaglar is a biosimilar from insulin from Lilly. Semglee came out with a biosimilar of Lantus. Notice Semglee just a little bit below the Lantus price from this is again list price. Insulin glargine at $99 is the same drug from Viatris. Viatris is the manufacturer of Semglee. They came out with two biosimilars at the same time, one with a rebate in it so that the pharmacy benefit manager would pick it up on insurance formularies, and another at $99 so that those that are hit with list price of drugs can have a better shot at affording their insulin. Still expensive at $92 and $73 and $82, but far better than paying $300 or nearly $300. But in what world does it make sense for a manufacturer to come up with a generic of their own drug? That only happens in the United States of America, and it happens because of the very bizarre marketplace dynamics that are driven by our pharmacy drug system.
Just a reminder too about those price tags. The price tags represent the list price, which is sort of the starting point for negotiation on all of these products. The net cost, which frankly is the cost that matters most to your constituents, could be much, much less, depending on whether the health plan they're in passes along those rebates and discounts, or if they're going outside their insurance and using a service like GoodRx or some of those coupon or discount programs that are available either through different companies or even through the manufacturers. It's possible to bring these costs down much, much lower than these list prices are. All right. So we talked a little bit about the technologies earlier, but we're going to sort of dig into what they are, what they do. Again, from a layperson's point of view, we won't get too deep into the technicals of it. But insulin pumps and continuous glucose monitors, or CGM, are wearable technologies, and they help sort of serve different functions that the pancreas can't. So an insulin pump, again, is a technology that a person with diabetes will wear. And instead of having to inject insulin with a needle and syringe, they'll basically wear an infusion set. And then that insulin pump will administer insulin at sort of based on an algorithm. It will dose or administer that insulin at certain frequencies. And then the continuous glucose monitors, as George had mentioned earlier, is a sensor that they wear that has basically helps measure the blood sugar. And it will provide not just that instant feedback of what the blood sugar is at the time, but really importantly, will provide some indicators on where that line is trending. So folks know if their blood sugar is going up. Or again, when we mentioned severe hypoglycemia earlier, if they see double down arrows or they know that it's dropping very quickly, they know that they can take steps to help bring that back up into safe range before they hit a point in care where they need someone else to step in and help. Those standards of care, as we mentioned, very much vary by diabetes type and particularly in underserved communities. So for example, when these technologies first came out, they were very much focused in the type 1 community. Increasingly though, a lot of people with type 2 are benefiting from something like a continuous glucose monitor, again, because it provides that real-time feedback of how food, activity, and other facets of blood sugar management how they impact those levels. So more often than not, we're seeing more people with diabetes are benefiting from these technologies. And they're reflected in the clinical standards of care from the Endocrine Society, the American Diabetes Association. All of the clinical specialists in this space are really looking more closely at making sure that these technologies are adopted earlier in a person's diabetes, a lot of times right at diagnosis, particularly in children, because of the benefits that they yield both short-term and over time to keep those blood sugar levels in check. And because they are, actually, we can kind of move to the next slide here. These devices are all very, very different. Their interfaces are different. Again, they're a wearable technology, so the user experience of both comfort, adhesive, there really are a lot of facets to these different technologies. So it's not just the job that they do, but how comfortable they are to wear, how easy they are to wear, how easy they are to read or to integrate with another technology. Sharing capability can be very different. So for example, a child with diabetes can go back to school and their parent is able to manage their blood sugar or monitor their blood sugar remotely and trade messages back and forth with a school nurse or another on-site care provider. So these innovations really have radically changed what's possible in diabetes management. I think the emphasis as policymakers is to make sure that these technologies are not treated like a luxury good. This isn't about having the latest and greatest device. These are similar to a prosthetic. These are basically technologies that are helping the person make up for having a pancreas that can't do what a pancreas is supposed to do. So they need these outside wearable devices to help them manage their blood sugar more readily.
Before you move on from that, Erica, I've been wearing an insulin pump for a very, very, very long time. One of the easiest things to understand about the value of this pump, even in the early days, was if I get a blood sugar that is maybe 160, my target's 120. If I were on an injection, a multiple daily injection, like the lower right-hand corner there, I would never have taken an injection. I would never have taken a shot of half a unit of insulin to try to knock it down 40 points. But with a pump, with an infusion set, I can quite easily take a half a unit of insulin and really dial the control of my blood sugars down. And again, couple that with the technology and the advancements of these continuous glucose monitors, it truly is a game changer. Prior to going on to the CGM, I did the math. I had pricked my finger 80,000 times in the 30 plus years of living with it. And the access, anybody on insulin should have access to a CGM. It is that much of a game changer in allowing them to really manage their disease. If you're on insulin, you should have a CGM. Doesn't matter what type of diabetes you have. The label of the type doesn't matter. You're on a drug that really requires the control and the measurement of that. And there's a couple of things coming in the chat on the cost of insulin. The Walmart revolutionizes access by creating a first and only private labeled analog insulin. And the thoughts on that, the question, I think that one, it's wonderful. Walmart, there's JDRF has a insulin that's going to come out as well, a couple of years away. It is a marvelous thing to lower the cost of the analog insulins that are available today. The issue is not every plan, it's just not reaching everybody yet. Although Walmart's got admittedly a huge footprint, they're still not everywhere. And the patient isn't always going there. So it's a major step and it will help drive the market, but the market's not there yet. And a patient living with diabetes, especially type 1, they need help now. But that is a fantastic step forward and will be driving this market in the right direction.
Since that question came up about Walmart insulin, George, can you take a minute and just help people understand the differences in the Walmart insulins that come up?
Yeah, so let's be clear, because this is the analog insulin. So this is a step forward. Walmart has always had insulin, and Walmart has always had relatively inexpensive insulin, but it's not the insulins of today. It's the insulins of the 1980s. When I first was diagnosed, I was on used to be R for regular, or NPH, which was a moderate would peak in 4 to 6 hours. Those insulins were human insulins and not analog insulins. I'm getting a little more technical there, but the easiest way to understand it is when you're on the human insulins, you are eating to match the insulin that you are taking. So your quality of life is quite different. I remember back in the day, I would take a shot of NPH at 7:30 in the morning, and it was going to peak somewhere between 11:30 and 1. If it happened to peak at 11:30 because I had been more active that day, it did not matter if I had a 12 o'clock lunch appointment or meeting with other colleagues. I had to stop and eat lunch at 11:30 and then sit and watch everyone else eat lunch. So I was eating to match the insulin when the insulin told me I had to eat. In today's insulins, these analog insulins, I now can take insulin to match the food I'm eating. So the quality of life is substantially improved with these insulins. It is much easier to control with the insulins available today. And these analog insulins aren't all that new. They've been around since the late 1990s, but they're just now getting into the Walmarts of the world. So the Walmart used to, and probably still does, would have the old human insulins, which is probably what you would give your cat or your dog if they have diabetes, which happens in many pet owners. But this isn't what we really want the your constituents to have in 2022. We want them to have the analog insulins, and they're starting to come out. And there's a lot of folks looking at this to try to get an option for their constituencies, and we applaud it.
And since we're looking at all of this through an innovation lens as policymakers, I think one thing to recognize is when you're talking about a Walmart insulin is to understand what that really is. And, as much as that's been sort of a bread and butter for a number of years, it isn't quite the standard of care. But also important to know that because it isn't the current standard of care, you have a generation or a couple generations of people with diabetes who don't even know those older insulins exist. It never has been part of their diabetes management, so they are not aware that that might be a possibility for them. But there's a safety concern. It's dosed much differently than what they are familiar with. So it's not as simple as just going to Walmart, getting insulin and treating it like you would any other insulin. It's a very different product, and it can be dangerous to not have the right coaching to administer it safely. And to that end, there are a generation of healthcare providers who have never had to manage a person's diabetes with those older insulins. They've only ever prescribed analog insulin. So there's a bit of an information gap along with the access and affordability gap, which is policymakers, people will be looking to you to help kind of build those bridges. So we're always interested in having more options for diabetes management, not less. So I think that access to lower cost insulin at Walmart is important. But I think having those new sources of analog insulins, be it the analog Relion, the Civica RX, which also was brought up, that is probably a couple years away from having a biosimilar insulin for each of those 3 varieties. And they right now are pegging the cost at about $30 per vial or $55 for a box of pens. So we're looking at a radically changed insulin affordability landscape in the near horizon. I'm actually gonna,
Brian Patrick is putting a question in here. And Brian, I just want to be clear. You're asking if the Blue Cross Blue Shield and Walmart insulins are not going to address the majority of people who rely on the new forms of biosimilar insulin products, since many of these are under patent. They actually, the the drugs, the analog insulins today, the Novolog, Humalog, and Lantus, all of those drugs are off patent. So the biosimilars that you're seeing coming out today are because of two things. One, they're off patent. So you're starting to see Viatris come out with Semglee, but they had to come up with a generic of their own generic. So they are in fact off patent. So biosimilars are now starting to come into the market and helping. And that is in fact why Walmart can come out with an analog. So the point here is Walmart has always had low cost insulin. Prior to their analogs, their new Relion with the with Novolog, those low cost insulins at Walmart were antiquated drugs that were not the current standard of care. This will be a game changer for folks as they get this out there to more and more, but it is just a short acting insulin. It does not have a long acting insulin to go with it. Unless you're on a pump, you need both types, short and long acting. If you're type 2, typically the type 2 start with long acting, but it's hard to really say that's a doctor-patient issue. So it's a major step forward. It's not the full solution yet. And to Erica's point, the more that some of these in Civica, which is a group that's coming out with biosimilars on all three types, that will be a game changer when that is out there. But it's a couple years down the line. And today, people need something. They need help for what they've got today. Let me talk briefly about prevention. There's diabetes prevention. There's two aspects of prevention that I'd like us all to think about. The first is to prevent or delay the complications. And the second is to prevent or delay diabetes in the first place. So there's preventing diabetes altogether, but once you have diabetes, we want to prevent the complications because the complications are what's driving the cost. As a public investment, those complications are what's driving the cost. It's the tail wagging the dog. And so we want to be, as we think about public health, we want to be thinking about both levels of prevention. So the innovation here is the recognition of diabetes and obesity as chronic conditions that can be medically managed. So first off, let's recognize that diabetes and of course obesity, which is driving the onset of diabetes, both of these are cardiometabolic conditions. These are diseases that can be medically managed, and recognizing that this is not the patient's fault. It's not the patient's fault that they have type 2 diabetes. It's not the patient's fault that they have obesity. They have a genetic disease, and it can be medically managed. Now, the fact that it can be medically managed is news. So there are new diabetes medicines that help protect heart and kidneys. These medicines have really improved over the last 5 years. SGLT2s, GLT1s, these are new medications. I'm not going to give you brand names for them, but they have come a long way in providing really significant protections for heart attacks and end-stage kidney disease. And that will hopefully help lower the burdens in the dialysis wards. In addition, there are new therapies and behavioral interventions available to manage obesity. 10 years ago, there was nothing to effectively to manage obesity other than diet and exercise. And everybody's going to say diet and exercise. If I just did diet and exercise, type 2 diabetes would go away. Unfortunately, that's not true because it's a genetic disease and the biology is fighting against the patient. So we know, unfortunately, that those that diet and lose weight typically gain, 90% of them gain the weight back. Diet and exercise, it has not been historically a long-term solution. There are now drugs that are coming out that will drop the help a patient drop their body weight by, right now there's the most The highest level that I'm aware of right now in a drug is 14.9% on average after 6 months of, so you're losing 14.9% of your body weight in 6 months by being on this medical therapy. There is a drug coming out that hopefully will be out by the beginning of next year that it will be in the 22% range within 6 months. That is a serious medical innovation that was not on the market before. Now, if you are driving a plan and you have some morbidly obese patients, you will pay today for bariatric surgery, but these medical innovations may well be much cheaper than bariatric surgery, and it's actually much easier on the patient, obviously. But these are things for the states to consider, Medicaid coverage and medication, and how much is going to get covered. These are things that you're going to have to be looking at as time moves on, and these drugs are becoming more and more prevalent in the marketplace, and they are actually helping people. This is not trying to get someone to fit into their summer swimsuit. This is taking someone who's in the true obese category and trying to make a significant improvement in their health to avoid the complications of either getting diabetes, or many people with diabetes are already obese. It will help prevent and delay the onset of those complications.
All right. Looking ahead. So we talked a lot about the innovations that are available today. We couldn't let you go without doing a quick nod to what's coming in the future. As we had mentioned, right now, a true cure for diabetes has been elusive. So we've focused on innovations that are helping people with diabetes manage the condition today, technologies that hopefully will help prevent more cases of diabetes in the future. A functional cure likely will come from insulins that are still in the pipeline to be developed. For example, a glucose sensing insulin, which instead of just kind of blindly dumping insulin into the bloodstream, that insulin actually detects the level of blood sugar that can help manage it. Again, keep it kind of surfing in that middle wave, like we showed in that graph, or a once weekly formulation. So instead of having to administer insulin several times a day, ultimately, maybe it becomes once a week. So again, those are big changes on the insulin landscape that people with diabetes are looking forward to. But that cure research really is kind of the holy grail for a lot of people, both for type 1 and type 2. The focus of that research has focused on stopping diabetes before it occurs. As we had mentioned, that is an autoimmune attack. So the body attacks its own insulin producing cells. So looking at how, how they can kind of turn off that autoimmune attack to keep those insulin producing cells healthy and doing their job. And the second kind of phase or flavor of research is restoring the body's ability to produce insulin. So that is where the innovation is heading. A lot of progress on that front, but obviously a lot more work to be done. And with that, let me jump over to our Q&A.
Yeah. So quickly, I just wanted to thank you both for the thoughtful presentation. And we've already seen a couple questions, especially thank you, Representative Kennedy, for reaching out with those. But we've seen a few of those questions filter in. So if you have, I think we'll have time for one or two here. Feel free to send those through in the chat. I guess one, I think you all had mentioned and kind of have seen what can be done for constituents who are calling about the price of insulin, and does you all had mentioned, does the Diabetes Leadership Council have any resources available to assist there?
Erica, you want to take that one?
Sure. The answer is yes. We have some resources on our website, diabetesleadership.org. We understand that insulin affordability is one of the most significant issues facing policymakers right now, because it is a struggle for too many families in the diabetes community. We also realized there's no one size fits all. There's no silver bullet to fix the problem because people's needs and circumstances varied. So what we have on our website is a list of a number of steps that people can go through to help reduce their insulin out-of-pocket costs. It's again, a much different landscape than it was even a couple of years ago. It's moving in the right direction, but a lot of people still need help.
And then I guess
anything to add to that?
Yeah. And then I guess as we wrap up here, does it cost states more money to cover new diabetes medicines, devices? Does it cost Medicaid extra money?
So the cost of adding any coverage, the question is, what's the offset? So if you add an insulin pump, what's the savings that happens by that patient not having the heart attack, not having the stroke, not having the ER visits? And so going back to that slide that showed 16 million ER visits a year. There are only 37 million people with diabetes and 16 million ER visits. That means we're doing a horrible job of managing this disease from a public health perspective. If we can lower that 16 million ER visits, the cost of the insulin, the drugs, et cetera, that's the tail wagging the dog. And the ROI will be exponential once we give the patients what they need to be successful while they deal with the 525,600 minutes of their life in a year and managing the disease.
Thanks, George. And so as we kind of wrap up here, I want to hope you all think me in joining our speakers, George and Erica from the Diabetes Leadership Council. If you might like to learn more about the DLC or any of these issues, you can visit their website, which is there on the screen, diabetesleadership.org. And as I mentioned in the opening, in the coming days, this session will be recorded and has been recorded and will be posted on the CSG website on our virtual innovation classroom registration page. We hope you all will join us coming up at 4 Eastern as we look forward to hearing from the GlaxoSmithKline Consumer Healthcare in their session titled Multivitamins, How to Leverage Science and Data to Transform Your Health and Wellness. And then to conclude our series next week, we will have 2 final sessions, one from the Security Finance and the National Public Pension Coalition. So we look forward to seeing you then. And thank you all again. And please, links there in the chat for the Virtual Innovation Classroom series. So we hope to see you again.